So this is the spectrum of ACS. So patients could present without symptoms, severe symptoms, or could present even with cardiac arrest. The ECG changes could be normal, could be ST depression, ST elevation, or could present with some form of malignant arrhythmia, which results in cardiac arrest. You could have a non-ST elevation acute coronary syndrome, or you could have a ST elevation myocardial infarction. And based on troponin, it could be a non-ST elevation MI, or it could be unstable angina. So this is the whole spectrum of ACS, and based on clinical presentation, on ECG findings, and on troponin levels. Now, so when a patient presents with symptoms, there is the initial ECG, which should be done within 10 minutes of arrival, and you might get a diagnosis straight away of ST elevation MI, in which case one proceeds with managing STEMI in the way that immediate reperfusion therapy. If on the other hand, there is either ST depression or T wave changes, then one needs to look further at the troponin levels and then risk stratify them based on the troponin levels. If the troponin is positive, then risk stratify and manage as non-STEMI. If the troponin is negative, manage as unstable angina. If the ECG is normal, if the troponin is negative and there is no rise and fall if it's at 0 hours or 1 hour or after 3 hours, then one makes a diagnosis of non-ACS or non-cardiac chest pain, and one needs to decide whether alternative diagnosis of chest pain or it's a non-cardiac chest pain that can be left alone. So the initial diagnosis risk stratification is based on history, physical examination, ECG, and cardiac biomarkers. In all patients, I think we need to emphasize, as soon as the patient arrives with chest pain, an ECG needs to be done and diagnosis made within 10 minutes of that particular ECG. If the initial ECG is non-diagnostic, then serial ECGs need to be performed. In all patients with chest pain, send an immediate high sensitivity cardiac troponin. There is an ESC algorithm which we look at in a minute of 0-1 hour testing, which will quickly rule in or rule out acute coronary syndrome. Now, if a patient presents very early after chest pain, say suppose the patient has 15 minutes of chest pain, comes to the chest pain clinic, and the 0 and 1 hour cardiac troponin is negative, then an additional 3 hour cardiac troponin needs to be done before one finally concludes that this patient does not have ACS. The other biomarker, CPK-MB, which is traditionally used to be done, is not recommended anymore. So this is the high sensitivity troponin. So there is a normal, and then there is the 99th percentile of the upper reference level, and above that is considered as abnormal. And I'll show you for each of the patients that presents, it is important to manage these patients. So if a patient has on the immediate ECG ST elevation, then it's an ST elevation MI, and that patient needs to go for reperfusion. On the other hand, patient has ST depression or T wave changes or a normal ECG, but pain is suggestive of ACS, then a troponin needs to be done. If a troponin is very low, one can straight away rule out an ACS. If it is low and a 1 hour change is again not significant, again it virtually rules out an acute coronary syndrome or a non-ST elevation ACS. If on the other hand it is very high, or there is a 1 hour significant change in 1 hour, then this is a patient who has non-ST elevation ACS, needs to be moved to a CCO, and then risk profile to decide whether it's high risk, intermediate risk, or low risk, and then the treatment follows that. Intermediate between high and low, one needs to do a 1 hour troponin. If there's a significant change, then they move this way. If there is no significant change, then again do a 3 hour troponin, do an echo, And if that's also not significant, then one might look at other diagnosis of